Welcome to The Explainer. Today, we are diving straight into the latest clinical practice updates from the 7th World Symposium on Pulmonary Hypertension. We're going to break down the new consensus on its definition, classification, and diagnosis, changes that are going to directly impact how we all manage these complex patients.
All right, so here's our plan. We're going to cover 5 key areas. We'll start with the updated hemodynamic criteria, then move through the refined clinical classifications, walk through the diagnostic algorithms step by step, and then wrap up with the most critical takeaways for your clinical practice.
Okay, first things first. Let's establish the precise hemodynamic values that now define pulmonary hypertension. These numbers, they're really the bedrock of our entire diagnostic process.
So here's the absolute headline change. The universal hemodynamic definition for pulmonary hypertension is now a mean pulmonary arterial pressure greater than 20 millimeters of mercury at rest. That's it. This value, confirmed by right heart catheterization, of course, is the new definitive diagnostic threshold, a really crucial update.
And once we have that diagnosis, the next question is, what kind of pH are we dealing with? And this is where we differentiate between pre- and post-capillary pH. It all hinges on 2 key variables, the pulmonary arterial wedge pressure, or PAWP, and the pulmonary vascular resistance, PVR. You can see here, pre-capillary pH is all about a low PAWP and a high PVR. On the other hand, post-capillary pH, which really points us towards left heart disease, is defined by an elevated PAWP.
This table really lays it all out for us, the complete set of the updated hemodynamic definitions. You can see the specific criteria for pre-capillary pH, for isolated post-capillary pH, and for combined post- and pre-capillary pH, which, you'll notice, is distinguished by that elevated PVR. And what's also really important here is the updated definition for exercise pH. It's now defined by an MPAP to cardiac output slope greater than 3 millimeters of mercury per liter per minute.
Okay, so we have the numbers down. Now let's move on to the clinical classification and see how we build upon that hemodynamic foundation. This is really where we translate those raw numbers into a meaningful clinical context for our patients. And, the good news here is that they haven't completely reinvented the wheel. For the sake of consistency, the core structure is retained. The report reaffirms that established framework of 5 major clinical groups to categorize all the diverse conditions we see associated with pH.
So, this table gives you that high-level architecture. Group 1, of course, is pulmonary arterial hypertension. Group 2 is tied to left heart disease. Group 3 is all about lung disease and hypoxia. Group 4 covers obstructions like CTPH, and Group 5, well, that's our bucket for unclear or multifactorial mechanisms. The whole point of this framework is to group together conditions that share similar pathophysiology and, importantly, similar therapeutic approaches. So while that 5-group framework is still our guide, the 7th World Symposium did introduce some really important updates. These are refinements to the classifications within those groups, and we need to pay close attention to them.
Right, so here are 4 of the most critical changes you need to know about. First, we see the reintroduction of the long-term calcium channel blocker responders as a subgroup. Second, there are new subdivisions in both Group 2 and Group 3. Third, there's a significant shift in how we actually classify Group 3 pH. And finally, an important update to the drug association list.
And this quote, it's straight from the task force. It really emphasizes why they made the decision to bring back this specific subgroup. The rationale is crystal clear. These patients are a distinct entity. They have a unique pathophysiology that's driven more by vasoconstriction. And, as you know, they have a significantly better prognosis and a very specific management pathway. Okay, let's look at the drug association table. You can see the 2 new additions are highlighted. Now, this isn't a small change. Based on a lot of mounting evidence, we're talking case series, registries, even experimental data. Mitomycin C and the proteasome inhibitor carfilzomib have now officially been elevated to the definite association category for PAH. All right, so we've covered definitions and classifications. Now let's turn to application. How do we actually put all of this into practice day to day? Let's walk through the updated diagnostic pathway together.
So the proposed algorithm is this really logical 5-step progression. You see, it all starts with clinical suspicion and some simple non-invasive tools. From there, it moves into a comprehensive heart and lung assessment. Then you've got specific tests like a VQ scan to rule out CTEPH.
And finally, for the right patient, it all culminates in that definitive right heart catheterization at a specialized pH center for the final diagnosis.
Now, within this whole algorithm, step 3 is absolutely pivotal. And the report couldn't be more explicit about this. Echocardiography is the single most important non-invasive tool we have for estimating the probability of pulmonary hypertension. It's our key screening tool.
And this slide just powerfully illustrates why echo is so critical. So have a look. On the left, you see those classic morphological changes we look for with pH, like the right ventricular dilation in the four-chamber view and that characteristic D-shaped left ventricle, the septal flattening, in the short axis view. Then on the right, the focus shifts to the hard numbers, the key quantitative parameters that formally increase the probability of pH. We're talking about things like an RV to LV basal diameter ratio over 1, or a shortened RV outflow tract acceleration time of less than 105 milliseconds, often with that telltale mid-systolic notch. You put them together, and these visual and quantitative signs build a really strong case for pH long before we get to invasive confirmation.
Okay, so we've gone through a lot of detail. Let's pull back for a second. What are the most crucial, high-yield points you need to take away from this comprehensive update? Let's synthesize the key shifts for your practice.
All right, here are the 5 essentials. Number 1, the new hemodynamic definition is an MPAP greater than 20. Simple as that. Number 2, the PVR threshold that defines a precapillary component is now greater than 2 Wood units. Got it? Number 3, the 5-group classification system is stable, but remember those important subgroup updates. Fourth, don't forget the 2 new drugs with a definite PAH association, mitomycin C and carfilzomib. And finally, and this is so important, adhere to that stepwise diagnostic algorithm and make sure you're referring to expert centers in a timely manner.
So this update gives us some really critical clarity for our practice today. But it also makes you think, right? It prompts us to look ahead. The report itself even alludes to a future where we might actually move beyond these broad clinical groups, a future where we have a more personalized classification, one that's based on an individual patient's unique genetic and molecular profile. It's a really fascinating prospect for the future of how we manage pH.